buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Antes de dar inicio a nuestra sesión, les recordamos mantener en silencio sus micrófonos. Durante la sesión pueden hacer sus preguntas a través del chat. Y al final de la sesión les pedimos que nos hagan favor de llenar una encuesta de satisfacción. En nombre de la Escuela de Medicina y Ciencias de la Salud, les damos la más cordial bienvenida y voy a dar el micrófono al doctor Oscar Tabés para que presente a nuestra ponente y conduzca esta sesión.
Muchas gracias, doctor Valencia, y bienvenidos a todos. Muchas gracias por estar aquí con nosotros. El día de hoy tenemos con nosotros en esta sesión de Pediatría de la Escuela de Medicina de Ciencias de la Salud de TechSalud una ponente muy especial. Ella es la doctora Hermione Lyall. Ella es infectóloga pediatra del Imperial College of London y vamos a platicar el día de hoy sobre el manejo de citomegalovirus congénito. Y para dar inicio formal a la sesión vamos a dar una breve introducción curricular de la doctora Hermione. Dr. Hermione Lyall is a consultant in pediatric infectious diseases at Imperial College Healthcare NHS Trust, and she's an honorary senior lecturer at Imperial College. She has great interest in congenital infections and their prevention, particularly HIV and CMV, and she runs both HIV and other congenital infection clinics at St. Mary's Hospital in London, and she is ward attending consultant for pediatric infectious diseases. She's a member of PENT-ID and she participates in HIV treatment trials for children. She's also a member of the board of the European Society for Pediatric Infectious Diseases, which is ESPID, and she has been actively involved in the development of international courses for education for pediatric infections for many years. So Dr. Hermione Lyall, thank you very much again for being here with us today to talk about this very interesting topic, which is congenital cytomegalovirus infection. The microphone is yours. Welcome. Thank you very much.
Well, thanks for that lovely introduction. I'm going to share my screen, I hope. So now, can you see that screen all right?
Yes.
Yeah, brilliant. Okay, well, thanks for the very kind introduction. And I'm going to talk about congenital CMV, which I think is really a Cinderella virus. And this is from the UK Parents of CMV web organization from their website, and they are a group called CMV Action. And in the UK, there are probably about 1 in 200 children born with congenital CMV, and that's almost 1,000 children a year. But most people have never heard of this virus, including a lot of healthcare workers. But almost everybody knows that a pregnant mother shouldn't go near the cat litter and a pregnant mother shouldn't eat soft cheese. But the chances of her baby being infected with either of these microorganisms is much, much less. And if you look around the world, the antenatal seropositivity for CMV is quite variable. But we know that it's young women who are most at risk of infection, and indeed women who are around young children and those who work in daycare. But the incidence of congenital CMV definitely changes around the world. And we'll talk a little bit more about maternal seroprevalence and the effect on that. But you can see that in different parts of the world, it's more or less frequent. I think if a mother has primary CMV infection in pregnancy, then she has about a 30 to 40% risk of transmission. If she has non-primary CMV, and usually this is more likely to be a reinfection, probably from a virus carried by a child, then the risk of transmission is much lower, less than 5%. But worldwide, there are more babies born with congenital CMV because of non-primary infection, because the majority of women around the world are already seropositive. And as far as the fetus is concerned, symptomatic disease and CNS deficits are seen as frequently in primary and non-primary infection. And this is a very big study from our colleagues in France, from Yves Ville and Marianne Lereuseville, who have worked in this area for a long time. Over 11,000 deliveries. They took saliva samples from the babies. They then clarified the babies who were CMV infected, and they were able to go back and look at the serology of the mother. And what they found was that the congenital infection rate was 0.37%. So in Europe, it's considered to be between 0.3 and 0.7. And whether the baby had a primary infection or a non-primary, the number who had asymptomatic or symptomatic infection was roughly the same. And the proportion who had hearing loss was also roughly the same. And I think it's very clear that the timing of CMV transmission in pregnancy is really important in terms of the damage that the virus can do. And the placenta does not seem to be able to protect the fetus from CMV. This data is from a relatively old collection of cases from the Netherlands, which showed that most infections probably happen in the third trimester, fewer infections in the first trimester, but by far the most damage happens where infection happens in the first trimester. And of course, for the majority of babies in the world, the time when most children get infected with CMV is after delivery. And almost all women who are CMV seropositive will excrete the virus in their breast milk, and most babies will be infected without any symptoms at all. So this is just the showing you from that Enders cohort that when you looked at the neonatal assessment of these children, about 20% were symptomatic at birth and 10% of those severe. But in the third trimester, they really said that there was very little in the way of symptoms. And I would just highlight that one of the issues about older studies is that they didn't follow children up for a particularly long time, not many beyond 2 years, and most of them do not have MRI scans of the brain, and we'll come back to that later on. This is, again, from our French colleagues, looking at a prospective cohort of 250 women and their fetuses and neonates, followed up, as I've pointed out, to 24 months. And what they said in overall, that the sequelae was there in about 16% of infants, but it was really all about babies who were infected in the first trimester. And they only found sensory neural hearing loss and or neurological sequelae up to 24 months of age in babies who were infected in the first trimester. Now, I think they did find that there were babies who had other babies who had mild or moderate speech delay, in particular, borderline delays, where there had been infection in other trimesters. And they were suggesting that this may be just the background level of delay. And unfortunately, obviously, there is there's no control group here. And I also just want to mention this prospective neonatal cohort that has been undertaken by our colleagues from Spain, by Dani Blasquez, where they, over a year, invited all the mothers to have their baby swabbed, and they found 0.75% prevalence in the saliva, and that was confirmed in half the number in the urine. And as we know, false positives are very common in saliva. So you have to be very careful if you're taking saliva swabs to make sure that you do not take them near to just after breastfeeding. They should be as far away from exposure to breast milk as possible. So they ultimately had 15 babies, so 0.47%, that same 1 in 200 again, who had positive urines. Now, looking at these 15 babies, none of them had hearing loss at birth. One had a retinal scar, one had abnormal LFTs, and one had sepsis. So none of these babies would have been picked up as symptomatic CMV. But 8 out of these 15 babies had abnormalities on their brain MRI. And I think this is the really crucial thing that we're seeing now, that we think these babies are absolutely fine, but actually we have some more concerns. And the majority of these infections were non-primary. There was no significant clinical differences in terms of these elements for the infected and non-infected infants. But interestingly, the infants who had abnormal brain MRIs did have higher viral loads in blood and saliva. So maybe that is telling us something about the level of activity of the virus in those infants. And following up those 15 infants, they lost 2 to follow up, but they had a follow-up to a median of 25 months. And you can see here that the majority had white matter abnormalities in the MRIs, some also with cysts. And you can see here the follow-up showing language delay and mild neurodevelopmental delay. And I think from my perspective, the problem is that at 2 years, at a median of 2 years, there may well be language and communication issues that are not actually readily picked up. And we see children who develop communication and autistic type presentations, which may not be until they're 3 or 4. And of course, children with hearing loss due to CMV, it can certainly be later than just the first 2 years of life, although that is when most of it does occur. So this was the classic paradigm of 10 to 15% symptomatic, 85% asymptomatic. But I think, we're moving on from that. I think you have to remember in that baby born with very obvious microcephaly, that is the baby who's going to have been infected early on, and where the virus, which is a neurotropic virus, is attracted to the neurons which form part of the early migration from the inner brain out to the cortex, and damage to this is what causes polymicrogyria, and that is what we see in babies who are infected early in the first and second trimesters. The babies who get infected in the third trimester, they don't have the migration abnormalities because the neurons have already done that and have not migrated normally. But these babies very commonly have periventricular cysts, and they can have ventricular stranding. There's an obvious ventriculitis going on there, and they certainly have white matter changes. Loss of brain tissue and microcephaly is really equivalent to infection in the first and early second trimester. And Dr. Lanziari published their findings of a cohort of long-term outcomes on symptomatic children. And this is 76 children followed up for a median of 13 years. And all of these severely symptomatic children had sensory neural hearing loss, half of them had severe intellectual disability, a third of them visual impairment, and you know, it was usually a combination of the above. And in this cohort, not surprisingly, microcephaly and an early abnormal CT was very predictive of long-term sequelae. And this is a study from South Korea, where they looked at a relatively small number of children presenting with symptomatic CMV, and they had a high number in there of premature infants, and it's certainly true that there are more babies born prematurely with CMV. Again, sensorineural hearing loss, microcephaly, delayed development, and epilepsy. And here they have MRIs, and nearly half of these children with severely affected had evidence of polymicrogyria. Ventriculomegaly, I think, is a little bit of a misnomer, because I think rather than big ventricles, it's more about small brain and loss of brain tissue. So one really follows on from the other. And certainly if you've got polymicrogyria, that is going to affect your development. That also increases your risk of epilepsy. And if you have calcification and polymicrogyria, both of those things definitely increase your risk of epilepsy. Sensorineural hearing loss was not necessarily associated with these severe abnormalities. Now, in a way, I am more concerned about the children who might be described as asymptomatic, because I'm concerned that we have not really appreciated as much as we could have the problems they might have later on, but also we may come across them at a time when there's maybe more we can do. Compared to a baby who in utero has already had severe brain damage. And here's an example, a baby born at term, a good birth weight, looks completely fine. And all that we find is that it's failed the newborn hearing screening test in one ear. It goes for formal audiological brainstem evoked potentials. They confirm the hearing loss. They test the saliva, and it's strongly positive for CMV DNA. So then we have to ask ourselves, well, what about the other end organs, the brain, the eyes, the liver, the bone marrow, and so on? The risk of deafness in the other ear, the risk of developmental problems, and that risk balance of treatment or no treatment. And I think we also have to just have a bit of a problem here, because what does asymptomatic actually mean? No signs or symptoms at birth. And I think we find it difficult to know whether the baby who fails the newborn hearing screening test, is that baby asymptomatic or not? And I think we actually need to review the way we assess these babies going forward. So here's the brain MRI of this asymptomatic infant. And you can see that there are cysts here. And you can also see that there is increased signal coming from the white matter. And what does that mean? Here's another baby where you can see the periventricular cysts, and you can see the white matter changes, particularly in the temporal lobes. This is a term infant, a bit growth restricted, and it gets picked up because the baby is mildly thrombocytopenic at birth and has a petechial rash. This is a baby asymptomatic, but has bilateral sensorineural hearing loss and has rather bright white matter. And is that normal or abnormal? So what about the long-term outcomes for these children who are asymptomatic? And we don't have a lot of studies that can help us here. This is a small study from Japan, where they looked at 72 cases and they have a relatively low transmission rate there. There were 3/4 of them asymptomatic, but at least it's taking a whole population, which is a good thing. And they followed them up. You see here, it's still relatively short, an average of 3 years, a maximum of 6 years. And what you can see is that the ones who were symptomatic at birth, 30% appeared to be free from sequelae. The ones who were asymptomatic at birth, 88% appeared to be free from sequelae. But what did these asymptomatic children actually have? Well, late onset sensory neural hearing loss. Even at a year of age, having hearing loss in both ears, and then speech delay and sensory neural hearing loss after 3 years. So quite a bit down the line, these children can develop problems. Autistic spectrum disorder at 4 years, and ADHD, so attention deficit hyperactivity disorder at 6 years. And this is the kind of thing that I'm a bit worried about. These are children who are getting into trouble and who are not doing well in terms of their education. And interestingly, they also had the viral loads and the weights at birth, and there really was very little difference. Now, my whole kind of attitude to CMV, congenital CMV, was changed by the CROCUS study, which is a study that was undertaken by colleagues in the Netherlands. And this had a very interesting design. And what they did was they went back to the babies who were born in 2008, when these babies were already 5 to 6 years of age. And they went to all the dried blood spots, and they obtained consent to test the dried blood spots. And they found 156 that were positive, bearing in mind that the sensitivity of CMV PCR on the dried blood spot is only 84–85%, which gave an estimated transmission rate of around about 0.5%, which is what you would expect. They then went to these families and asked them if they could link up the CMV result with what had happened to that child in terms of their development, their health, and their education. And they've got very good national health records in the Netherlands. Interestingly, of the 133 families who gave consent for the babies to be followed up, and they also had 2 matched controls for each of those children, you can see that 20% of those babies could have been called symptomatic at birth, but actually only 3 of them was diagnosed at birth with CMV, and only 1 of them was treated. So most of these infants were completely missed. And when they did that assessment, a lower number than has been seen in other cohorts, but only 5 children had developed sensory neural hearing loss, and all of these were children with congenital CMV. And I think it's really, what we can see here is that the moderate or severe long-term impairment was twice as common in the children with congenital CMV compared to those who did not have CMV. And of those who were symptomatic at birth, half of them had impairment and fewer who did not. And what comes out here very strongly is this issue about speech and language. And this is what we see really quite frequently. So to me, this changed the paradigm, and this made me consider that congenital CMV has a much wider spectrum of effects in children than we appreciated previously. And indeed, if you look at the epidemiological studies of hearing loss, which have been undertaken, those asymptomatic children, about 14% of them have developed sensory neural hearing loss by 5 years of age. But most of the hearing loss really does happen in those first 5 years, and subsequently it's really quite rare. The other important thing is that if you already have unilateral hearing loss, then you have a much higher risk of going on to lose your hearing in the good ear. So this is bad news. If you've got unilateral hearing loss, then you have a much higher risk of actually going on to get bilateral hearing loss. So this is our own data from St. Mary's, where I work, and where with my neuroradiology colleagues, we went back and reviewed all the brain MRIs of the children who've been referred to us over the last few years. And we've got about, sorry, there's an A that should not be there. So we've got 71 children. And literally, a bit like we saw in that Spanish perspective cohort, around about 50% of the asymptomatic infants had abnormal MRIs, whereas it's more like 70–80% of the symptomatic infants. And what we see in these asymptomatic infants is particularly white matter and cysts, but even some of these infants have had polymicrogyria, whereas polymicrogyria is much more common in the symptomatic ones. So, as I've pointed out, if you've already had severe damage in early gestation with loss of brain tissue, what is postnatal antivirals going to do for this infant? It's not going to bring those neurons back. On the other hand, if you have later gestation infection and you have white matter changes and cysts, could postnatal antivirals actually make more of a difference? And the trouble is, we have no studies which have quantified CNS damage versus effects of antivirals. And we don't really know whether the benefits could actually be greater in these less severe infants. There are a number of clinical trials, particularly looking at treatment for infants with hearing loss, which are currently underway. And we'll get more information in the next few years, and that's going to be very important. We generally in the UK follow the European consensus on treatment, and our consensus is that we would advise treating any infant with CNS disease, other severe disease. We wouldn't treat children with really no evidence of any disease anywhere. But we don't have total consensus about what do you do with a child who has isolated sensory neural hearing loss at birth, but a normal MRI scan and no other signs of disease activity. Should we treat that child or not? And you know, we haven't got data to help us with this. The only randomized control trial that we have of oral valganciclovir, I'm sure you all know this well, is from David Kimberlin and the CAS group, where the randomization was to 6 weeks or 6 months of oral valganciclovir. And the follow-up was relatively short at 24 months. And that did show some improvement in terms of preservation of hearing, and better neurodevelopmental outcome for the infants who were treated. But it was moderate. And just to say, there was a high rate of prematurity. There were not, a lot of children did not have an MRI. And you can see here the CNS involvement was said to be about 3/4, although a third of them had microcephaly. Those that did have neuroimaging, 3/4 or so had abnormalities. So in the conclusion, the author said treating symptomatic congenital CMV with valganciclovir for 6 versus months versus weeks, did not improve hearing in the short term, but appeared to improve hearing and developmental outcomes modestly in the longer term. But important to remember, there were only about 100 children in this study altogether. So the numbers were small and the imaging was mainly CT or ultrasound. So what are the risk versus the benefits of treating that asymptomatic infant? And at the moment, we can offer 6 months of valganciclovir and or audiological and developmental follow-up. And valganciclovir is a drug which has short-term toxicities, including neutropenia and hepatitis. So the baby will need monthly blood tests. And then there are these concerns about long-term toxicities as to whether it's a carcinogen or a teratogen. There is some animal data to suggest this, but we do not have solid human data as such. And this is why we really need an international registry of children born with CMV so that we can see what happens to them in the long term. A post hoc analysis was carried out in the Valgan study to actually see whether the viral load had an important part to play. And not surprisingly, there were higher baseline viral loads in those with CNS disease, thrombocytopenia, and transaminitis. However, overall, the conclusion from the authors was that there was no clear negative or positive predictive value. And I think there's no kind of clear cutoff levels. That more symptomatic infants had higher viral loads at baseline, but it didn't help to predict the long-term outcomes. So with all these questions, with my colleagues from ESPID, we have joined together to create an international network so that we can put together a registry and collect data on infants with congenital CMV. So this is a cohort registry. So we want to be able to get as many children as possible so that we can understand more about the epidemiology and the clinical characteristics. We want to evaluate the risk factors for long-term sequelae. We want to be able to look at more prognostic values of neonatal variables, document treatment strategies and outcomes, and very importantly, long-term and short-term adverse events. So we've set this up this year, and Daniel Blanquez in Madrid with Estrella Escavil de la Fuente. Daniel is the leader of the database. Myself as the chair, Vana Papalangelou is the secretary, Despina, our education officer, Horst, our treasurer, although we haven't really got any money, and Simon Drysdale, our research officer. And the aim of the network is to be collaborative and to gain as much information as we can. And for those who join, if they want to bring forward research proposals, these would be presented to the steering committee and taken forward as appropriate. So the database has been approved by the ethics committee of the hospital in Madrid, and it's now been opened out. It's a very user-friendly REDCap database. It's now been opened out to colleagues all over Europe and indeed further afield. And if any of you would be interested to join, I'll show you the email link at the end. But through this, we really hope to get better population data, understand, help us to begin to understand the correlates of disease and treatment efficacy in relation to immunology and virology, work with other collaborators to start thinking about new treatment strategies, and of course work with families as well. You know, we want to think about new and less toxic treatments and whether there could be different durations of treatment as well. We've also started a monthly virtual clinic, and in fact, we've got our second one later on this afternoon. And there, colleagues can bring cases that they're working on and discuss it with the team and decide, you know, who would treat this child, who wouldn't treat this child, what do we think is the right thing to do. So if you'd like to join, just send us an email at ccmvnet@gmail.com. Currently in the UK, we're undertaking the ethics application. And for those of you who know, a great tragedy for us in the UK is that because of Brexit, we've left the European Union. So that's now become a bit more complicated. But, you know, we welcome anyone who would like to participate. And thanks for listening, and hopefully I might be able to answer your questions.
Thank you very much, Hermione, for your brilliant presentation, and we're very thankful for the time you took to explain all these very important topics and relevant situations about asymptomatic and symptomatic children, because that usually is a dilemma. So we have a few questions from the audience that maybe you would help us to further address. I'm going to start reading them, and then if you have some comments, please. So what should be our concerns or advices to parents in prenatal consult regarding CMV? Should we be talking about CMV with pregnant women, some restrictions or some recommendations? What would you recommend?
Okay, so I think that's a really important issue, and there are clinical trials which have demonstrated that if you advise women about simple hygiene measures, so washing their hands if they've been feeding their children, if they've been changing a baby's nappy, not kissing babies on the mouth so that they get exposed to saliva, not eating the food that they've been feeding their children. If women take these simple hygiene measures, then they are not so much at risk of being infected or reinfected with CMV. So I think that is something that can be done by any woman. And interestingly, I think, you know, we will see what has happened during the COVID time, that there may actually be less babies who've been infected with CMV because people have been circulating less. There have been less people going to nursery and playgroup and all these kind of things. So there are simple measures that you can take. At the moment, there is not a vaccine for women. And I think it's really hard in some countries. Women who are seronegative, in some countries, they can be tested to see if they become seropositive. But since that is actually the very small minority of women, I don't think that is, you know, in most countries, most women will already be seropositive. So that's not going to help the majority of women. So I think it's about the simple hygiene measures.
Okay, thank you, Hermione. I'm going to jump the next question because you mentioned something that might be useful for this one. So what are your thoughts about universal CMV screening during pregnancy? In Mexico, we have both public and private practice, and in public practice, some legislations or some changes to usual practice might take a little bit longer than private practice. So would you recommend universal CMV screening in such scenarios? And if so, in which trimester would you recommend?
So I think the problem is that if you do screening, so if you screen women in the first trimester, you will get those who are already seropositive. Well, all you can do for them is give them advice about how to avoid infection in the virus in the future. But bear in mind, if you're already seropositive, for that individual woman, the risk of transmission to her baby is relatively low. It's probably less than 5%. The woman who is seronegative, you can give her the same advice, and you know, in some countries, they will then do regular repeat serology to see if she seroconverts. Now, some of you may be aware of a randomized control trial that has been reported last year from Israel, where women who seroconverted in the first trimester were treated with very high dose acyclovir. But those women were literally screened every week and then started on treatment, which I think is very, very invasive. And there was, to some extent, an improvement in the outcome for the babies who were treated. As the sooner the mother got onto the treatment, the better. But generally speaking, to apply something like that on a kind of programmatic national program, I think would actually be extremely difficult. And ultimately, what we need is for women to be, you know, the possibility for vaccination early on before childbearing, I guess, is what we should be aiming for. And I think actually that now that people are so much more aware of viruses, you know, that's one thing that COVID has done, then hopefully it will help to raise the profile of Cinderella viruses like CMV.
Thank you very much. And regarding MRI scans and, you know, how invasive they might be because of sedation and all the process we have to go through in neonates, would you recommend MRI scans for every asymptomatic child, considering risk
Yes.
and benefit?
So we normally would do an MRI scan in a baby under 12 weeks. We do what we call a feed and wrap. So we just make sure the babies had a really good feed and swaddle them up nicely, and they sleep very well, and you don't usually need any sedation. So if you've got a team that is kind of well organized, you can definitely do very nice and good MRI scans on young infants without sedation. The problem about only doing ultrasound scans are very good for showing cysts and very good for showing calcification, but they're not so good at showing what's happening in the white matter, and they're not so good for showing whether there's migrational or structural abnormalities. So if you really want to get a good picture of what is going on, and particularly of the inflammatory process in the white matter, you really need an MRI, I would say.
Thank you very much. We have two more questions. One is a very specific question from the audience. For how long would you expect LFT elevation in an asymptomatic child?
So do you mean with treatment or without treatment?
Without treatment.
Okay, so the babies who have abnormal LFTs because of congenital CMV, I think you sometimes see two different pictures. You can see a baby who has a mild hepatitis and just has a little bit of abnormal ALT or AST, and usually that settles down very quickly. On the other hand, you can get babies who have really quite nasty hepatitis, and they usually also have conjugated hyperbilirubinemia. They sometimes look that horrible kind of greenish yellow color. They may have very big, hard liver, also big spleen, and that can be abnormal for months and months. And you need to get support from your hepatologist. But those babies definitely need to be treated, because they can have abnormal LFTs for a very long time.
Thank you very much. And the last question before we thank you again for your participation here. Is there a benefit on trying to look back at children who have hearing loss and trying to look for CMV in case they had it, and if there's any intervention or treatment strategy for them?
So I think that's a really important question. And so a baby who passed the newborn hearing screening and seems to be fine, and then for whatever reason has a hearing test maybe 6 months or a year or 18 months later and is found to have hearing loss, going back to the neonatal dried blood spot to look for CMV, I think is really important for two reasons. One is that it's actually very important for the family to know what the cause of the hearing loss is. And it also prevents you having to do lots of other investigations to find the cause of the hearing loss. It also helps to give the family an idea of what to expect and what other things might be going on. The other thing is that with the current clinical trials that are underway, it may be that there will be the possibility of treatment in the future for a baby who, or a child, a young child who's diagnosed with hearing loss. So you would want to know, particularly to protect the hearing in the good ear or to protect what hearing is left in the bad ear. Now, there is a study called the Toddler Valgan trial, which was taking place in the US and in the UK, which has completed but has not yet fully reported. But that study probably hasn't shown a difference in terms of treatment or not in older children between a month and 4 years of age. But the problem there is that the numbers are very small. There's only 20 children in each arm. And the treatment was only given for 6 weeks. And it may be that 6 weeks is not enough. And the other important consideration is really whether it's just antivirals that you need or whether you actually need some other immune modulatory therapy. Is it by this time the virus that is causing the problem, or is it the immune response that is causing the problem? And the trouble is we really don't yet know the answer to that.
Thank you very much. Well, thank you very much, Hermione, again, for your brilliant presentation and your very useful thoughts and answers for all these questions from the audience. We are very happy to have you here, to have all this relationship with you and your institution. So thank you very much. And I'm going to close the session in Spanish. Muchas gracias a todos los asistentes. Thank you very much. Muchas gracias. Y recuerden que hay que llenar la encuesta de satisfacción. Cualquier pregunta, tienen el contacto tanto de nosotros como de la doctora. Ryan, thank you very much. Hope to see you soon.
Okay. Bye-bye. Very embarrassed I can't speak Spanish, but I send you my best wishes. Bye.
Thank you very much.